Okay, so picking up where we left off, renal disease. The largest population of transplant recipients are in need of a kidney. So the kidney is by far the most common organ that's transplanted. And what is the role of the kidney? It excretes nitrogenous waste. It regulates fluid volume, composition, and acid-base balance of the blood, and then synthesis of hormones necessary for erythrocyte production, bone metabolism, and maintenance of blood pressure. So the kidneys are pretty darn important. Signs and symptoms of renal disease or kidney disease: decreased urine output. The volume may remain the same, but what the contents of the urine may be decreased. Hypertension, anemia, cardiovascular disease, fluid retention, edema in the legs, ankles, feet, fatigue, drowsiness and or confusion, shortness of breath, seizures or coma in severe cases, chest pain related to pericarditis, and then skin conditions. So the clinical manifestations are very long for chronic renal disease. We want to look over the table on in the 5th edition, it's table 54.1 to see all the body systems that can be affected, because it's really a very long list. And I'm not going to test you on a lot of that because that goes into great detail. The stages of kidney disease, basically it has to do with the GFR. A lot of it has to do with the rate of the GFR, which is glomerular filtration rate, and the most accurate means of measuring renal function is the glomerular filtration rate, and that is an expression of the quality of glomerular filtrate creates each minute in the renal nephrons. So it's the quality of the filtration essentially. So stage 1, renal damage with normal GFR, which is greater than 90, at or greater than 90. And then and you might not have any symptoms here at stage 1. Stage 2, renal damage with mild decrease in the GFR, so a number between 60 to 89. Again, there may not be any major symptoms. Moderate, the GFR just keeps getting lower. Anemia and bone metabolism disorders become more common. Chronic kidney disease is defined by kidney damage or a GFR that's less than 60. Stage 4, severe reduction of GFR, 15 to 29. End stage or kidney failure, you're under 15 in the GFR. Risk factors for chronic kidney disease: adults with diabetes, high blood pressure, cardiovascular disease, obesity, and then a family history of chronic kidney disease. So systemic conditions: anemia or a lowered number of erythrocytes or red blood cells causes fatigue and weakness, infections because of a weakened immune system, low calcium level and high phosphorus levels in the blood causing bone problems, high potassium level in the blood causing an irregular heartbeat or pulse, loss of appetite or reduction in food intake, excess fluids in the body causing high blood pressure, swelling or edema in the legs and feet, shortness of breath because of fluid in the lungs, so pulmonary edema, depression or a lower quality of life, and then premature death likely due to heart disease and stroke. So chronic kidney disease affects many body systems, as you can see. So end-stage renal disease. So what is happening here? Patients are on dialysis. Dialysis is a treatment method of cleaning and filtering waste and toxins from the blood when the kidneys lose function in end-stage renal disease. So it removes salts and extra water to prevent them from building up in the body, maintains a safe balance of certain chemicals in the pH, such as potassium, sodium, and bicarbonate, and it helps to control blood pressure. So that's what dialysis does. There's a couple different types of dialysis. There's hemodialysis, which is someone goes into a dialysis clinic and all their blood basically kind of filters through a machine and then goes back into their body. And then there's CAPD and CCPD, which is continual ambulatory peritoneal dialysis and continuous cyclic assisted peritoneal dialysis. Those, I believe, are almost methods that are done at home or with a caregiver. And one is not considered superior. There just depends on a patient's, basically like a patient's lifestyle and the ease for them to come into a clinic, or is it easier for them to have it done at home? How ambulatory are they? That sort of thing. Consult and obtain clearance from a nephrologist. Confirm patient is, now we're talking about types of dialysis and alterations in care. So alterations in dental hygiene care for a patient on dialysis. We want to consult and obtain clearance, first of all, from their nephrologist, and then confirm the patient is medically stable enough to receive treatment. Determine if prophylactic antibiotic is necessary. It oftentimes is. Do not take blood pressure on the dialysis access arm. One of their arms will have a port or a fistula, and you do not take blood pressure on that arm. That's very important. Avoid dental treatment the day of dialysis due to the use of their anticoagulant therapy. So they're going to bleed more, and so you want to make sure that if they have dialysis Monday, Wednesday, Friday, that you only do a dental cleaning on a Tuesday or a Thursday. Consider the function of the compromised organ and how malfunction of this organ will affect body systems. So considering, what areas of their body is weakened due to their chronic disease, how is that going to affect their mouth? How's that going to affect infection? How's that going to affect all the different roles? So for example, they're going to be more prone to hypertension and diabetes. That's going to put them at greater risk for periodontal disease, maybe xerostomia and decay because of their medications. Everything is connected. End-stage, so dental hygiene, process of care considerations continued. End-stage renal disease patients are prone to secondary diabetes and hypertension. Secondary medical conditions are not part of the original etiology of the disease, but rather a complication that develops as a result of the disease, such as things like fluid retention, anemia, hyperparathyroidism, or malnutrition. These next couple slides, there's a lot of information here. These are oral manifestations, sort of the description, and then the dental treatment considerations. So these are things that could show up in your patient. I'm not going to read off the dental treatment consideration, but I highly encourage you to read through these tables. So pallor of the oral mucosa, this has to do with anemia. Pale appearance of the oral mucosa results from anemia. Xerostomia, dry mouth, reduction in saliva flow results in dry mouth, caries, gingival disease, and viral and fungal infections. Red or orange pigmentation of the cheeks and oral mucosa, this is pruritus, severe itching of the skin, dryness of the skin, and depositions of keratin-like pigmentation results from a decrease in the renal filtration. Oh gosh, I thought that was dyspnea, but it's not. Dysgeusia, altered or metallic taste, sensation. Saliva may exhibit a characteristic of like an ammonia-like odor resulting from high urea content. So the patient may complain of a strange taste in their mouth. They've probably known what it is. It's the fact that they have a higher urea content. But if you notice sort of a particular odor that doesn't smell like periodontal disease, it doesn't smell like, kind of a GERD, stomach upset, or just biofilm, that's what it can be stemmed from. Bacterial, viral, and fungal infections. Fungal infections, candida, are more frequent, resulting from reduction or lack of saliva and immunosuppression. Petechiae and ecchymosis and gingival bleeding. Bleeding tendencies observed on the oral mucosa, soft palate, border of the tongue, gingiva, resulting from thrombocytopenia, infection, medications use, and use of anticoagulants such as heparin. So the bleeding disorders have a lot to do with medication, especially anticoagulant. Dentition abnormalities of the children. Enamel hypoplasia, red brownish discoloration of teeth occurs in children. Delayed or altered eruption patterns. Dental pulps may have appeared narrowed. This is if there's chronic kidney infection or chronic kidney disease with a child. Dental erosion or lingual surfaces on the erosion on the lingual surfaces. Erosion of teeth is associated with regurgitation and persistent vomiting from high levels of uremia. So this could be a result of a side effect of their end-stage renal disease. Uremic stomatitis. Two forms. There is erythropoiesis type, features dry erythematous, burning, painful oral mucosa that is covered with a thick gray exudate. The ulcerative form is characterized by mucosal ulcerations. So uremic stomatitis can appear sort of two different ways. Looks very kind of ulcerated or covered with like a thick gray smear. White patches of uremic frost, crystallized or powder-like urea deposits that can be found on the skin or oral mucosa, resulting from excretion of nitrogenous compounds in the sweat observed in severe uremia. Osseous changes of the maxilla and mandible, loss of lamina dura, demineralized bone characterized as ground glass in appearance, and localized radiolucent lesions. Central giant cell granulomas may also appear. Infection or inflammation of the periodontium, periodontal or endodontic abscesses, periodontitis. Periodontal inflammation may be more severe than for normal biofilm-induced gingivitis. Periodontal attachment loss may result from poor oral hygiene, lack of biofilm removal. And then a patient that has chronic kidney disease or end-stage renal disease has increase in calculus formation, and this is because dental calculus formation arises from uremic status and duration of renal disease. Okay. So medical considerations for chronic kidney disease patients. There's a greater risk of cardiovascular disease. They almost always have anemia in end stage, reduction in mass or of circulating red blood cells. Nearly all people living with end stage renal failure have anemia. Oral manifestations of anemia is the pallor of the oral mucosa, glossitis, recurrent aphthia, candidus, angular cheilitis, and possibly poor oral hygiene due to fatigue. Mineral and bone disorder. Excessive secretion of the parathyroid hormone affects this. Kidney loss, ability to excrete phosphorus from the body and produce the active form of vitamin D. So there's usually deficiency in vitamin D. Must limit the phosphorus intake because they can't secrete it. Vitamin D supplements and phosphorus binders are recommended. Renal-friendly diet. Patients work with a nutritionist because they're on a very strict diet when there's end-stage renal or chronic kidney disease. Oral manifestations, calcium deposits on and in the teeth, the soft tissue, the vasculature, and our organs. Calcium deposits in the carotid artery may be visible on a panoramic radiograph. Narrowing of the pulp chamber, so that's more calcium deposit within the pulp chamber. Various radiolucencies, the loss of the lamina dura, trabecular pattern, and bone density changes. So I'm going to read my other notes here. A serious complication of chronic kidney disease characterized by an excessive secretion of parathyroid hormone is known as mineral and bone disorder. formerly referred to as secondary hyperparathyroidosis. As renal disease progresses, the kidneys lose their ability to excrete the phosphorus from the body and produce the active form of vitamin D necessary in bone metabolism. Persons with mineral and bone disorders must limit phosphorus intake. In addition, they need vitamin D supplements, and a medication known as phosphorus binders may be prescribed to reduce the absorption of phosphorus. Nutrition. So renal diet, there's a restriction on fluid and the sodium intake. Limit the dietary phosphorus and potassium. Consult with a nutritionist about products that are ingested or that are safe for the patient to ingest. Protein levels may be higher or lower depending on their stage of renal disease. Uremia compounds the dental calculus problem. So we already mentioned that they may have more calculus because of uremia. Salivary pH. Uremia alters the pH of blood and saliva. Science is unsure if uremia is actually protective against dental caries, but we know that it's causing more calculus buildup, so it may increase perio. Xerostomia and fluid restrictions, they're going to have dry mouth due to the fluid restrictions, but also due to the medications they could be on. So things like xylitol, frozen grapes, power toothbrush, and oral irrigator, sleeping with a humidifier. These are some recommendations. And then, but consult with the renal dietitian. Let's see, I think my notes are all pretty much just a repetition, but as kidney disease progresses, nitrogenous material accumulates in the body, producing a condition known as uremia. So that's what we keep talking about, uremia, but that's what it is, an accumulation of nitrogenous materials. Nearly 50% of adults with chronic kidney disease suffer from dry mouth, which is possibly caused by a restriction in fluid intake, adverse effects of drug therapy, and salivary gland hypofunction causing a low salivary flow rate. And mouth breathing is also secondary to lung perfusion problems. So there's many issues that could contribute to a dry mouth. So dental professional recommendations. Because of the taste in their mouth, to help stimulate the saliva and to alter that taste, they could have sugar-free candies. Mechanical stimulation, power toothbrush, xylitol containing chewing gums and lozenges. Foods such as apples, carrots, and celery are naturally cleansing and okay on a renal diet. Pharmacological stimulation, drugs that require a prescription such as pilocarpine HCl or Sevimilin HCl. So those pharmacological stimulation. I am not quite sure if that has to do with hyposalivation or xerostomia. I'll have to look that one up. Over-the-counter saliva substitutes. This could be the pharmacological stimulation, could be saliva substitutes, I think. We have to double check that one. Over-the-counter salivary substitutes, chewing on ice chips, and then sleeping with a humidifier. So, for considering periodontal disease for the chronic kidney disease patient, at best there's a moderate relationship that exists between periodontal disease and renal insufficiency. The relationship between the two diseases are still being researched. The risk for periodontal disease appears to be significantly increased in individuals with severe renal disease, which makes sense because so many other, there's so much body system being affected, and we know that cardiovascular and diabetes affect perio, so it sort of makes sense that it falls in line. Increased levels of calculus formation on teeth, so that's going to increase their risk for perio. patients' noncompliance or improper oral hygiene procedures just because of fatigue or just being overwhelmed or what have you, exaggerated inflammatory response associated with alterations in host defense mechanisms because of the immunosuppression. Secondary hypothyroidism can contribute to accelerated bone loss in the presence of periodontal disease. Frequent 3 to 4 month continued care intervals appropriate are recommended. The dental hygienist will either coordinate with the primary care physician or the healthcare specialist to determine safe and effective care before and after transplantation. And the last slide here just shows the nephrology team. There's the nephrologist, there's a nephrology nurse, there's a renal dietitian, there's a nephrology social worker. They help coordinate all these aspects and transportation and all these things, dialysis, all this stuff. Patient care technician, pre-transplant and post-transplant coordinator. Then there could be the patient's regular physician. They could have a cardiologist if that's something too. I mean, there's so many aspects. It can be so very complicated, and we need to be very understanding with our patients that come in. If they are able to get into our chair, we're lucky that they were able to make it that far, and we just want to make sure that we provide safe care. And so being aware of all these pieces is basically our job. And that's renal disease. All right. Thanks, guys.